All right, good afternoon. Welcome, everyone. Thank you all for joining us today for our VLC session entitled Working Across the Health Department and with Other State Agencies to Increase Collaboration on Viral Hepatitis Prevention and Surveillance Activities, made possible in partnership with the CDC Division of Viral Hepatitis. Hello all, my name is Zakiya, Grubbs, she, her pronouns, and I'm a manager on the hepatitis team here at NASTAD. Joining us today are several presenters, including Sarah Weninger, the HIV, STD, and Hepatitis Prevention Coordinator from the North Dakota Department of Health and Human Services, Sophie Lewis and Linda Goldman from the Massachusetts Department of Public Health, and also we have Liz Sweet, the Systems Integration Coordinator from the Iowa Department of Health and Human Services. All right. The format for today's session is as follows. We will begin with presentations by Sarah, Sophie, Linda, and Liz, and we'll have just a few minutes for a brief Q&A. So feel free to introduce yourselves in the chat and let us know what jurisdiction you're coming from, and if you all have any questions during the presentation. On March 22nd, also at 3 p.m. Eastern Time, we will continue this conversation in the form of breakout sessions, 3 different sessions with each of our presenters from each jurisdiction. And you'll have an opportunity to ask some additional questions about their presentation today. So hopefully y'all will be able to join us on the 22nd, and I guess we can get started. So thank you all again for joining us. All right, Sarah, you want to get started?
Yeah, all right, here we go. And you can see my slides, correct?
Yes.
Okay. Good afternoon, everyone. Thank you, Zakiya, for having us talk today. So my name is Sarah Weninger. I'm the HIV, STI, and Hepatitis Prevention Coordinator with North Dakota Health and Human Services. And I'm just going to talk about the work that we're doing across agencies to impact viral hepatitis prevention and surveillance. So just a few things. We're going to talk about our structure, some surveillance, and then relationships across different programs. One thing that's new in North Dakota that happened in September of 2022, our Department of Health and Department of Human Services officially merged as of September 1. And so sometimes I still catch myself calling us the Department of Health, and there's tons of people who still call us the Department of Health. And I still don't know my own structure within our HHS. Am I a unit? Am I a section? Am I a division? I don't know. They all changed. And so I'm still getting used to it. But with that merger, it has been helpful. And I think it'll get even more helpful as our divisions still are figuring out priorities and workflows and things like that to better even align the services that we provide. The focus of our new HHS is citizen-faced focused, where they're trying to merge any services that a citizen may come across in one, like a streamlined fashion, instead of having multiple different, like, for example, I think they often use as food stamps, like WIC and food stamps or something, were in 2 different entities in 2 different buildings, and they are now in one. And so eventually, hopefully all of that happens for a person and their behaviors, and not necessarily having to go to multiple different places. So our public health division, where our unit falls, and the behavioral health division that offers services for substance use disorders, are now within one agency. And so we're hoping that that allows us some flexibility to further integrate our programs and our missions together. One thing that we've always had in North Dakota, we are not a high morbidity state, not a super intensive resource state either. And so we've always had to be a little bit creative in our handling of different things and making the most of what we do have available. And so our particular unit is called the Sexually Transmitted and Bloodborne Diseases Unit. I think it's a terrible name, but that's what they saddled us with. And it also includes TB. That just kind of has fit within the development of our program over time. So our program, or our unit, has HIV, STIs, viral hepatitis, Ryan White, and TB, all under one division director. And so it's a very tight-knit group. We've had some very core stability in our program. That's also helped us. We haven't had a ton of turnover. And so that has been really great. Over time, I've been with our agency for the past 15, 16 years. And when I started at the health department, I was doing viral hepatitis surveillance, STI surveillance, and foodborne outbreak investigations. Very odd combination, but that's kind of just how the leadership structure was at the time, and knowledge and preference. I've been there a long time, and have had like 5 different job duties and never have applied for a new job. And so we've done some restructuring to make us more efficient. And so right now I'm HIV, STIs, and hepatitis prevention. And then I have a counterpart that's surveillance. And honing and developing those skills has been really helpful, especially on the surveillance side. Getting all of that experience and knowledge in one place versus having to kind of feel like being pulled in multiple different directions. And so just even that simple reorganization has certainly helped us become more efficient. As I said, we are under the same agency as Medicaid, which has been good for our relationship development with them. Just a few things about our surveillance program. Of note, we have one data system. We call it Maven, and Maven is integrated across all of our programs. So we use Maven for our disease surveillance. Our Ryan White case managers use it. We use it as a system to document our testing program. So our HIV and Hep C testing program, all of our testing sites use Maven to enter their data in. Our syringe service programs use Maven. So any condition that we work with is all in Maven. And so if we search for an individual that has Hep C, we can see if they have HIV. We can see when they were last tested. We can't see syringe service because that's de-identified, but it gives us a very holistic picture of the person. And so our Maven system is so valuable to us. And so one thing that we did across our programs is we developed a position called the data quality coordinator. And that individual has been producing some reports for us that give us real-time data analysis on our surveillance data so that we don't have to utilize like an Excel table to try to figure things out. She's using Power BI that produces reports that you can see in real time, like how many infections you have. For my testing program that I'm in charge of, I can see how many people are positive, how many people are they also testing for HIV, all kinds of different things. That's super helpful, improving data quality, and especially in a timely manner. So we're super excited about that integration of surveillance. One reason that North Dakota needed a stronger relationship with Medicaid, as you can see, we are still one of the states, I think we're ranked like the 7th worst as far as Medicaid grade. And we haven't had a ton of movement in improving the access to care for patients with hepatitis C with our Medicaid program. We've made some strides, like for example, even before we officially removed the need to have a approval or prescription from a specialty provider, our Medicaid was making exceptions for certain clinics. If they had a good plan in place and consulted like a yearly plan with a provider. So they were showing signs that they were willing to start making some exceptions or making some movement in the restriction access for hepatitis C. And so we kind of been poking and prodding for a couple of years on, about Hep C and access to care, and it comes up, and then it comes like other entities bring it up, like our tribal health folks. And we slowly but surely have been making some progress. And so just recently, now that we're the one division or one unit, whatever we are, Medicaid is very willing to do a lot of different things with us now. For example, they freely shared whatever data we wanted, they were going to share with us so that we can compare it to our hepatitis C surveillance system. And so what they gave us is like name, date of birth, their Hep C status, and things like that. And we were able to determine the number of Hep C infections that are currently enrolled in Medicaid and the number of infections that we have that either are listed as like chronic hepatitis C or something like we might need to follow up with them to see if they've been treated or that they need treatment. And what this allowed for us to do is start a conversation with Medicaid about developing some strategies to get more individuals access to Hep C treatment. Apparently, our Medicaid office doesn't have strong abilities to do a lot of data analysis, and they don't do a lot of like follow up on past infections or like cases or things like that. And so our ability to analyze their Hep C data was really helpful for them. And now it's going to be helpful for us because they're willing to think of different strategies to expand access for treatment, right? Right now, we still have restrictions based on sobriety for Hep C treatment. They're likely going to be working on and proposing to remove that this summer with some caveats. And the caveats aren't great, but they're better than where we're at now. And one thing that we helped with Medicaid was with STI workforce funds, we were able to hire some additional DIS staff. And some of those DIS staff are nursing staff. And we offered them up to Medicaid to be like, we could somehow integrate these DIS into Hep C treatment follow-up because our Medicaid office was concerned about the number of people who were going to start treatment and then not finish treatment. And so we provided some solutions to their concerns so that when they hopefully do open up treatment, that they're going to see people complete treatment and can consider that a good public health investment. And so this is just some of the data that they were able to give to us. And what I find interesting, if you look on the bottom chart, blue and orange, blue is Medicaid and orange is non-Medicaid. Of our people that are diagnosed or reported to us for the first time in 2022, almost half are Medicaid patients. And so hopefully if we develop these good partnerships and show that DIS can help with like a treatment plan and a follow-up, like a weekly contact point for patients on treatment, we can see them through treatment. Hopefully this will be a good way to get access for more people on for Hep C treatment. So with Medicaid, one other reason that our Medicaid office has really been super great to work with now about hepatitis C, they're open to having syringe service programs start treating hepatitis C patients, is the development of our Hep C Advisory Council. Our council right now is working on a Hep C elimination plan for North Dakota. We have a lot of great partners on it. We have a lot of great providers that are very passionate about hepatitis C. One thing that's interesting is this is all about integration. Our Hep C Council was previously integrated with our HIV board. That board was primarily focused on HIV, and the people on the board weren't super great representation for Hep C. So we actually found it better to separate the two and have our own Hep C council. And this council has been meeting since December. So only a few short months, and pretty much already have a draft of an elimination plan because they're so focused and have such great knowledge and experience with Hep C. And so we're super excited about their work that they're doing. And as far as like Medicaid goes, and the people that are on this board have talked about prior authorization is a big problem in North Dakota. It's very difficult. We have a infectious disease provider who said that they have one nurse for their office that's doing prior auths, and she retires at the end of the year. And when she retires, they're going to find someone who will fill it out and take the time to learn because it's so convoluted and just so time intensive. And so with the plan and with Medicaid being on our advisory council, they have agreed to develop a work group to streamline that process and possibly remove a lot of the more difficult parts of that prior authorization. And so we're making some really good strides with this council and Medicaid and treatment access. One of our other great partnerships is with our Department of Corrections. Our Department of Corrections used to be down the road from us before COVID. And then when COVID hit, we got kicked out of our building and now we're all at home. But you literally could walk down the gravel road and there would be corrections. And They have a provider there who's been there about 15 or 20 years, and he is a very passionate provider about correctional health and treats correctional health as public health, and have been very instrumental to work with and very proactive about Hep C, and has wanted and advocated for Hep C treatment for all of their inmates every single year. Currently, they screen all patients or all inmates for HIV, Hep C, chlamydia, gonorrhea, and TB. They have about a 15% prevalence in our correctional system, and they treat about, with the current budget that they treat about 43%. This next biennium, which starts in July, they've asked for a little bit of an increase to treat more people, but they do some good work with treatment, and then other things like syringe education about preventing reinfection, linkage to substance use treatment, counseling, things like that. They're preparing them for a life once they do get released. So they're doing really good work in our correctional facility. We actually just met with some staff at CDC talking about the model that our physician is using, because they're very impressed with how much Hep C work that they're doing, and perhaps utilizing some of those things in a nationwide effort, because our corrections does use 340B to access cheaper costs to get more people treated. The one great thing that's come out of our relationship with corrections is we don't have a lot of great treatment data. If you ever have seen a Hep C surveillance report form, it's like 2 or 3 pages with like symptom history and testing history and risk history, and it just is too long and lengthy. And so that report form just is not a realistic option to complete. And so now our surveillance epi is invited to their weekly ground rounds that they have at the correctional facility, get access on treatment data for all the people we're going to treat. So our surveillance epi started with the new funding that we received, and has been trying to beef up our data around how many people are getting treated. So we're super excited for that. Behavioral health, we still have a little ways to go in behavioral health. And the most important thing is we are collaborating, we're meeting. They're trying to work on policy things within their programs to make sure that sepsis screening is happening. They're making sure they bring it up with all of their partners. We use behavioral health funding to support our syringe service programs. And so we make sure we meet monthly with them to keep those collaborations going. We have had to work with other entities to develop a full-time workforce. We only are allowed so many FTEs with the health department. And so with our local university having a public health program now, they are willing to contract with us and create full-time positions with benefits that we wouldn't be able to otherwise have. And so that is a relationship we're working on to develop a detailing program, to do provider education on different topics related to HIV, STIs, hepatitis, and a little bit of TB. And they also have a Center for Collaboration and Advancement in Pharmacy, where we're working with them on expanding pharmacists and their ability to provide rapid testing, as well as some syringe service efforts. So things are coming from there as well. And there's my contact information if anybody has any questions, and I'll turn it over to the next speaker.
Thank you very much. I think that is me. I'm going to share my slides. Hopefully. Okay, can everyone see them? I can see them, so I'm assuming everyone can see them. Hi, everyone. I am Sophie Lewis, and I am a consultant with the Massachusetts Department of Public Health and the Bureau of Infectious Disease and Laboratory Sciences. And I will let Linda introduce herself.
Hi, everybody. I'm Linda Goldman. I'm the Director of Health Promotion and Disease Prevention Services in the Office of HIV/AIDS at the Massachusetts Department of Public Health.
And we are going to talk today about our surveillance and our service system and how we collaborate across those programs. And just to frame this a little bit, in Massachusetts, the viral hepatitis grant is used to support primarily capacity building work. So what we're going to talk about today is how we work across the Department of Public Health, and then how we use data to inform the capacity building work that we're going to do, both what agencies we're going to work with and what the capacity building needs are. And Linda, you are up.
Okay, so in order to provide some context on what Sophie is going to discuss, I'm going to give you all some information on the service system we promote and support here at the Massachusetts Department of Public Health. So back in 2010, we embarked on a journey toward an integrated service system. And year after year, we continue to progress toward a more integrated system. What Sarah talked about earlier had a lot of, resonated a lot, I think, with us in sort of how we look at our service system here in Massachusetts in the context of integration. And the topic of this session is obviously about working across the health department and other state agencies to increase collaboration on viral hepatitis prevention surveillance activities. And we all know that integration is not possible without collaboration. So that's really what I'm going to focus on in the few minutes that I'm going to speak today. So in Massachusetts, we think about integration in a few different ways. One way is across infectious disease services. And due to the populations that our funded agencies serve, having shared experiences of social determinants of health and intersecting risks, we've integrated many of our services. One example is that all of the serum specimens that agencies submit to our state public health laboratory are co-tested for HIV, hepatitis C, and syphilis. And we also encourage agencies to collect and submit urines and use swabs for extragenital testing for chlamydia and gonorrhea. Agencies we fund also have an option to provide TB testing. When we promote vaccination services, often we promote sort of a range of vaccines for clients. One thing, sort of an unintended but good consequence of our getting involved in COVID and Mpox vaccinations is that several of the providers that we asked to participate in those initiatives were testing HIV, hepatitis C, and STI testing and linkage services providers or harm reduction providers in our service system. And what many of them did would be to offer hepatitis C, HIV, STI screening, testing, and linkage services and or harm reduction services, along with a COVID or Mpox vaccination when someone came in for those or presented for those vaccinations. So a lot of people ended up getting introduced to our sort of broader range of services through those vaccination efforts. In terms of case management and health navigation, we used to fund only HIV medical case management. And for several years, we've also been supporting hepatitis C navigation to help people access and complete hepatitis C treatment, TB navigation primarily for latent TB infection, and also PrEP navigation. So we've used a lot of the strategies and expertise learned in the HIV system and applied them to navigation for these other infections and treatments. Similarly, we used to fund only HIV home delivered meals and have more recently expanded to fund medically tailored home delivered meals for people while they're undergoing hepatitis C treatment. We're expanding to serve people while they're undergoing TB treatment. And we actually provided one client who was on treatment for Mpox with home delivered meals. So that's a flexible service. We also expanded our HIV correctional linkage services to include people who have diagnosed hepatitis C infections. And those services help people who are incarcerated link to hepatitis C treatment after they leave incarceration. And our HIV drug assistance program became an integrated drug assistance program, which now offers assistance with PrEP and TB in addition to HIV. We also help pay for hepatitis C for people living with HIV. Another area where we focus on integration is with respect to prevention and care. So basically what we do is we have every agency we work with has one contract manager. All the services are kind of bundled into sort of one massive set of services. It gives the agencies a lot of flexibility with respect to service delivery, staffing. They can move funding resources around from one service budget to another within the context of sort of particular funding requirements. And it also had helped them diminish reporting burden, which is a nice sort of administrative benefit for them and for us. But our main purpose in integrating the services was really to simplify client access and to acknowledge that the silos of prevention and care have really been artificial for quite some time now. And it makes sense to offer services to people irrespective of sort of where they are in that sort of care, prevention care continuum. And then across infectious disease and substance use harm reduction services, we also promote integration. I'm going to speak a little bit more about that later. But we do work very closely with our Bureau of Substance Addiction Services on a range of harm reduction services and other services such as rental assistance, housing, church advocacy, legal services, which we wouldn't be able to offer the way we do without funding from our Bureau of Substance Addiction Services and their collaboration. So Sophie, next slide, please.
Sorry, I'm trying to, here we go.
There it is. So I'm not going to read this whole list of collaborative partners, but I wanted to make sure people had sort of an idea of the breadth of collaborative partners we work with. And like Sarah mentioned, we also have a lot of strong connections with our correctional health system. Within our bureau, we have a lot of different teams working on viral hepatitis work and other work. And as I said earlier, we collaborate with our Bureau of Substance Addiction Services, environmental health, which pays for our syringe disposal kiosks. Our Bureau of Community Health and Prevention often will tell us about service gaps that they identify for populations that the agencies they fund serve, and then we'll come in and partner with them to try to figure out how to address those gaps together. We worked with other of these bureaus on COVID testing, COVID vaccination, and other services. And basically, like I said earlier, we're only able to accomplish all that we do if working hand in hand with these organizations. We also work very closely with our City of Boston Public Health Commission on many different activities. In terms of, actually, Sophie, go back, I'm not quite ready yet. But in terms of funding, we leverage a lot of different funding streams. Like, as I mentioned earlier, we've got this big integrated set of services. This is just a sample of the primary funding sources that we use to fund this service system. They're all integrated in one contract. It means that it's often a lot of work on the back end, administrative and fiscally for our team. But from the provider side, the goal is to have services as sort of seamless and integrated as possible. So we create this very complicated puzzle using all these different funding streams. We have about 50 different ways of characterizing different services and their funding streams. But it all works out in the end. Sophie, now you can progress to the other slide. Okay, so I'm going to give a couple examples of how we work really effectively with our Bureau of Substance Addiction Services. Some of the work that we do is related to Narcan distribution. We call it overdose education and naloxone distribution, and also housing services. So our partnership has facilitated a massive amount of service expansion in Massachusetts, particularly in the past couple of years, since receiving an infusion of federal and state resources that are focused on addressing the opioid epidemic in Massachusetts. So this Bureau of Substance Addiction Services, which I'll call BSAS, so they receive a lot of these resources, and BSAS actually transfers a subset of those resources to us and our Bureau of Infectious Disease and Laboratory Sciences. But we work together to try to make sure we can promote a comprehensive set of services for people who inject drugs, people who use drugs. So together, we've been able to add millions of dollars to the service system over the past couple of years. We've added Narcan services in new cities and towns. We've added new HIV, hepatitis C, STI testing venues. We've expanded interdisciplinary teams. And something really exciting about this is that in addition to adding health navigators to the system, we've been able to fund clinicians like NPs who can prescribe hepatitis C treatment and help people get on PrEP, and also provide advanced vein and wound care. This has allowed for a significant increase in hepatitis C treatment access throughout the system. And some of the agencies are providing treatment on-site at syringe services programs. They're outposting at SSPs, and there's even one or two agencies providing hepatitis C treatment via telehealth. We also, through our collaboration, have been able to buy at least 18 vehicles, vans and RVs, some of which are customized in very impressive ways. And they're bringing these interdisciplinary teams, often with clinicians, not always with clinicians, but always with harm reduction staff and testing staff, out into the community. They're able to get into encampments. They go to shelters, they park in parking lots, park outside clubs, and it's given them a lot of flexibility to bring services out in the community to folks. And then I'll just mention this permanent housing, low threshold housing program that we worked on with BSAS. We were seeing a lot of people sort of growing encampments in Massachusetts. And in 2021, we collaborated on designing a low threshold permanent housing program with supportive services, starting in the city of Boston. BSAS now coordinates it, and we've expanded statewide. And now there are over 400 people who previously had been experiencing homelessness, many of whom were in encampments and on the street, and they're in permanent housing units with supportive services. And there's actually been very little turnover in those units, and it's been a huge success. Next slide. So this is just a picture of one of the vehicles that our collaboration enabled an agency to fund, and they've used it for our services, but also it's been handy for Mpox and COVID vaccination and testing. And one more slide. I'm not going to read through everything, but just to show you how our harm reduction system has grown over the past several years. You can sort of compare the numbers of clients, the numbers of syringes distributed and collected from 2015 to 2022. You will also see that the volume of testing really hasn't increased in proportion to the increase in clients and service interactions. And Sophie's going to talk a little bit more about that, but we're working on it. You'll also see in the second slide that our co-testing of serum specimens for HIV hepatitis C has meant that there's sort of parity in those numbers now. So that is what I'm going to cover today, and now I'll turn things over to Sophie.
Thank you, Linda. So I'm going to talk really briefly about two current projects that we have going that are using surveillance data as well as the service data from the range of services that Linda just discussed. So I'm going to talk about a project looking at strengthening hepatitis C linkage, which is using both surveillance and service data, and then a project that's focused on drug user health services using primarily service data. So for the linkage to hepatitis C care project, the providers that are funded by the Department of Public Health for testing are expected to link everybody who is diagnosed with Hep C to a hepatitis C prescriber and to confirm attendance. And they're supposed to document the outcome of that linkage, including who attended, whether or not they attended or not, was there any follow-up, did they report already being in care, or did they decline care? And these agencies submit these data to the Office of Healthcare Planning, and the Office of Healthcare Planning also has access to electronic lab reporting data. So I have a little graphic here, and I see that many of the EPIs that I work with are on this call, so I hope that I'm going to get this right. I think I am. So the testing site, they are submitting specimens to our state public health laboratory. State Public Health Laboratory, those results are going into MAVEN, which is the same surveillance case management system that Sarah talked about. And then the testing sites are also submitting their testing outcome data to the Office of Healthcare Planning. Office of Healthcare Planning is accessing ELR data, so they're able to look at both what is happening in terms of labs and what agencies are reporting in terms of outcomes. And this project is looking at what that comparison looks like so we can show providers how they reported an outcome versus what we actually see in Maven as a proxy for linkage to care, do we actually see a lab for a client that they reported as having gone into care and seeing a hepatitis C prescriber? This is what the report looks like. Their report is actually much longer than this, but this is the primary table that we're working with. And so providers are able to see with this provider, for example, they had 152 people that tested HCV NAT positive. And of those, they referred 28 people to care who they marked as having attended the appointment. However, when we look at whether or not those clients all had labs, they didn't all have labs. So we're looking at 12 of those who the provider said was in care, but we didn't have a lab. And just to jump down to the line of people who reported already being in care, agencies reported 71 folks as saying they were already in care. However, we see a large percentage of them as not having a lab within 90 days. And we would expect to see a lab if somebody was in care. And then also an item of interest that providers were really interested in, that folks that they reported as declining care, which is this number, number 30 here, they actually did have a number of people who had follow-up labs. So even though some clients were declining care in the moment, they were eventually getting into care and within 90 days. So we reviewed these reports with providers. We were able to show them their service data compared to surveillance data. And in particular, the areas that I just highlighted, people who were in care but didn't have labs, who declined care but did have labs, and the high number of people who did not have any follow-up. And as these discussions, we were able to do some pretty quick fixes with agencies, as well as some longer-term technical assistance. We've talked with them about whether or not they were actually confirming appointments, and they weren't, so now they are. We discovered that they misinterpreted link to care as meaning they thought it was linked to a PCP and not a hepatitis C prescriber. And the same with being already in care, they thought that that meant linked to a PCP as opposed to being in care with a hep C provider. And they weren't following up with people who reported already being in care. So that's something that they're doing now, and we're interested to see what, if anything, looks different. The data team have developed the next round of reports, and we'll be starting some additional TA in FY24. The other project, I know I'm almost out of time, I'm going to talk really quickly. This is a capacity building project for SSPs, and we're using service data for this, and the goal is to strengthen drug user health activities. And SSP providers are expected to gather a range of information from clients, and that all gets reported to the Department of Public Health. Again, it's the information that Linda covered in the services. And we use the service data to identify SSPs that were in need of TA and to inform the kinds of activities that we are now doing with them. We looked at baseline data. I'm not going to read this, but we looked at all of these data points to help us identify who to work with. And then we selected SSPs that either had low testing numbers, low linkage numbers, low referral to MOUD, and low referral to SUD. And we also included some SSPs that expressed interest in offering on-site treatment, immunization, and on-site prep. And these are the different capacity building activities. We have done an in-depth assessment with all of them, which informed the other pieces, which is process map development with some group coaching, which is sharing best practices, and then a 12-session learning collaborative, which we are almost at the end of with this current group, and we'll do another round later this summer. And that is it. These are our email addresses if people have questions, and hopefully we'll see you all in a couple of weeks to have a longer discussion. So I'm going to stop sharing and turn it over to Liz.
Thank you, Sophie. Just a moment while I pull up my presenter notes. Gotta find them. Okay, so I'm Liz Sweet. I am the Systems Integration Coordinator with the Iowa Department of Health and Human Services. So today I'm just going to talk really quickly about my position, as it's usually a topic of interest, as well as our cross-sector work, some of our data-informed prevention efforts, and then also discuss some of the work we're doing in component 3, which was the competitive portion of the viral hepatitis grant focused on people who inject drugs. So first, just wanted to talk a little bit more about my position as the Systems Integration Coordinator. This position has been around for the last several years, and it is a shared staff member between the department's Bureau of Substance Use and the Bureau of HIV, STI, and Hepatitis. And so from the start of me being in this position, I've been embedded fully in both bureaus as an employee. So I mainly serve as a liaison between the two bureaus and coordinate collaborative work, identify opportunities for collaboration and integration using a syndemic approach and really focused on harm reduction. I assess needs and develop training, education materials for the workforce as well. And what we've done is used braided funding to support the position. We've used CDC opioid data to action grant funding, which is a substance use focused grant. Of course, CDC viral hepatitis, specifically component 3, and then also the state opioid response grant from SAMHSA, which is also a substance use focused grant, as well as some state funding. And we're able to do that through a contractor that partners with our bureau. And so I did start as a contractor a few years ago, and now they were able to bring me on as a full-time employee. And I've really seen that this position is really essential for some of those cross bureau efforts. And then just talking about cross-sector efforts, I lead a couple of these cross-sector groups that we have at the state that really help inform our work. And so the first one is the HIV and hepatitis community planning group. So that's kind of the traditional HIV and hepatitis group that involves people with lived experience from the community, as well as professionals engaged in prevention work in the community as well. And then I specifically lead an advisory group that's called Iowa's Health Initiative for people who use drugs, otherwise known as HIPWOOD. And this is a cross-sector advisory group, kind of mirroring the CPG group above, but really with a focus on substance use and lived experience of substance use. And so it's those individuals as well as folks from a wide variety of sectors everywhere from corrections to treatment centers. And then a newly formed group is the Syndemic Work Advisory Group, call it SWAG, which I'd also help facilitate. And that is more of an internal Iowa HHS group that has staff right now from the Bureau of Substance Use and the Bureau of HIV, STI, and Hepatitis with a syndemic focus. And our goal is really to align the efforts across the state in addressing the syndemic, and we'll eventually go on to include additional stakeholders as well. So I wanted to talk quickly about some of the data-informed prevention efforts because we really use our data to inform the efforts that we're doing across Iowa. So the two kind of primary strategies that we use are to first work with systems to increase routine screening in primary care settings, and second, to use data sources to inform the development of policies and practices that direct safety net services with limited resources to reach prioritized populations. And so we partner with a wide number of providers to achieve these goals, including our contractors, which are called our integrated testing services that cover a lot of the state with their 12 different sites. And I'll show you that on a map here in a second. We partner with our federally qualified health centers to implement routine screening. We also partner with our substance use treatment locations that are offering now hepatitis C screening and HIV screening as part of their medication for opioid use disorder services. We also partner with our community-based screening services that are organizations working with STI testing. And then we also partner with some community-based pharmacies that have been providing free hepatitis C screening in areas that were identified as vulnerable to HIV and or hepatitis C outbreaks related to injection drug use. And so this is a map of all those partners that I was talking about. The shaded in is where our contractors with the integrated testing sites or ITS are. And you can see that we have a lot of counties first, but also that Southeast Iowa is largely not covered directly by our ITS contractors, but this has been identified as a vulnerable area for populations at risk. And so building capacity in that area of the state has been a focus of ours. And that's why, you see some of those other partnerships that we have down there with the little triangles that cover that state area of the state and not necessarily our ITS alone. And then across all projects, the program reported a 2.33% total positivity rate in 2022, which was down from 3.06 in 2021. For substance use treatment centers that are delivering medication-assisted treatment for opioid use disorder, you could see had the lowest amount of hepatitis C tests, but the highest rate of positivity at a little over 11%. And obviously this can be attributed to the prevalence of hepatitis C transmission among people who use injection drugs and the increased likelihood that people who inject drugs will be encountered in settings that provide treatment options for substance use disorders. And this slide shows there's a lot of information here, but I'll just highlight a couple things. It shows the number of hepatitis C tests at our ITS sites in the blue bars, and then the associated positivity rate with the gold lines between 2018 and 2022. So you can see over time, our number of tests at those sites have decreased, but the positivity rate has stayed the same or increased in the most recent year. And that's because our programs really prioritize the use of hepatitis C test kits for people with a history of injection drug use. And then you can also see, like I said, the really increased positivity rate in 2022, which again is attributed to the increased funding, especially through component 3 of this grant, where we were able to prioritize additional assessments and linkages to care for people who inject drugs. And then this slide highlights the total Iowa diagnoses of chronic hepatitis C in the entire state, which is the blue line, and then those identified within the ITS programs that we fund, so the gold line down there. And there was actually an increase of over 46% of cases identified by ITS programs between 2021 and 2022. And again, this is largely a result of the increased efforts over the last couple of years to focus on prioritizing people who inject drugs. And decreases in overall Iowa total diagnoses is largely attributed to decreased cases among the baby boomer population, according to preliminary data from 2022. And in 2022, also preliminary data suggests nearly half of all newly reported cases of hepatitis C in Iowa were among people who inject drugs. So again, just a population and that we've identified as a population in need. And so now I want to talk about component 3, which is where I focus a lot of my efforts and where a lot of our collaboration has come into play. And so, like I said, you're probably aware that this is a competitive portion of the grant, and it's focused on increasing access to prevention, diagnosis, and treatment of Hep B and C, HIV, bacterial and fungal infectious disease, consequences of drug use among people who inject drugs. I'll preface this by saying that SSPs are not legal in Iowa, and we only have a couple SSPs operating underground, and so we had to be really creative in the way that we approached this part of the grant. And so we first identified some of our ITS contractors to implement an additional, what we call a supplemental assessment. And so they do some additional questions and linkages to care for people that are identified as persons who inject drugs. We also identified additional funding, specifically through the SOR grant, to support expansion of our harm reduction lockbox program that's co-located with syringe disposals at 19 sites across the state. And so that was kind of our way of getting more harm reduction supplies out there without having SSPs located across the state. And then most recently, we're partnering with an emergency department to provide opt-out testing for HIV and hepatitis C. And this is also in partnership with our local recovery community center that is a peer-run organization that has peer recovery coaches. And so they'll be co-locating this project so that after a person is identified in the ED and tested, that they can be linked to a peer recovery coach and have that continuity of care that the ED generally otherwise would not provide. Really quickly, this is where our location of the syringe disposal locations are. So a couple areas across the state, and we're working to hopefully expand that. And then a couple other projects that we've done as part of component 3. One, we've worked with our pharmacy association to do a survey for pharmacists and pharmacy techs. And this was an assessment to understand syringe and naloxone access at local pharmacies. And that's, again, because SSPs are not legal in Iowa, but pharmacists can sell a syringe without a prescription. And so for a lot of folks, that's really the only access point to get sterile syringes and needles. There's also a naloxone standing order in place that pharmacists are able to utilize in Iowa. So our naloxone access isn't as widely available as some other states. And we also consulted with our HIPWOOD advisory group that I talked about earlier and people with lived experience to develop the survey to make sure it was really community informed and help us identify things that we really could educate pharmacists on in the future. And then our primary care association we're partnering with as well to implement the PWOOD service bundle in behavioral healthcare settings at the FQHCs, as well as using our ECHO model for hepatitis C treatment. And in year 3, we're proposing to support staff of a contractor with lived experience. And then the last thing I'll talk about really quickly is kind of a unique opportunity that we identified to support our syringe services programs in the state without being, able to have them legally available. And so we recognize our harm reduction organizations really struggled through the pandemic, as well as, with the limited funding available to even maintain or increase efforts in spite of increased overdose and infectious disease transmission. But we identified what we could do to support them with allowable activities in the state that are considered legal. And so we have developed a contract to fund them to do HIV and hepatitis C outreach, testing, and linkages to care, as well as doing harm reduction and overdose prevention outreach and education in the community. And so that was a braided funding effort that was between component 3 and, again, the state opioid response grant. And so they were subcontracted to provide those funds, and then we are assisting in training, technical assistance, and hoping to increase staff time. And then this is a pilot project that we're doing at one of the locations, and so we're hoping to expand that in the future and continue to support harm reduction in our state. And that is all I have. So there's my email, as well as an email for Cody Schaefer, who is one of the other main leads on this grant.
Well, thank you all so much for sharing with us today. Those are really great presentations, and I know I appreciated learning so much about all the partnerships that you all have been developing. We have a few minutes for questions, so folks feel free to unmute yourselves or write in the chat. I did also want to mention that we will have a follow-up breakout sessions on March 22nd, where you all can ask more in-depth questions with each of our presenters. So we hope to see you all then, but I'll leave it up to you all to ask any question for our presenters. And thanks again for our presenters, such great information. Well, I did see a question from Wendy in the chat, and she was wondering how these collaborations work, especially on the local level. So I don't know if our presenters, they all presented from the state, but maybe if you all can discuss your relationships with local health departments and how that worked, or anyone on the line from a local health department can discuss some of the partnerships that you all have facilitated. So.
I mean, depending on your structure in your state, as far as state public health versus local public health, it might differ, but I think one thing that is needed before, you know, at the state level and the community level is leadership buy-in. And so that's something that's really propelled our work, is a really strong belief in the need to collaborate. And so I think, you know, with our collaborations happening at the state level, that is helpful for those at the local level as well, to see that, you know, the state's doing it. And so, you know, maybe we should be doing that as well. We're also going through an alignment similar to what South Dakota was talking about. And so we are in a lot of spaces working at the state level and the local public health level to make sure that our services are integrated, and that we're taking more of a syndemic approach to everything rather than being in silos. But I don't have any specific, you know, local public health experience in that area.
I guess maybe Linda or Sophie, you can discuss how y'all work with City of Boston. They have like a minute left, so.
I think that's you, Linda.
Yeah, just quickly, and about counties, we don't have a county system of public health in Massachusetts, but we do work closely with local health departments across Massachusetts. We've had a very long-standing close relationship with the Boston Public Health Commission. We've actually at times procured services together, particularly Ryan White Part B services, you know, recognizing that we're funding the same services and wanting to make sure that clients, irrespective of where they live in Massachusetts, have access to the same types of services. We've partnered on training and TA initiatives. We've been doing a lot of work together more recently on addressing HIV outbreak, and an HIV outbreak in Boston, and then challenges for people who are using drugs, who are living in encampments in Boston. We've collaborated a lot on our CDC funded ending the HIV epidemic work. So we do a lot of work together. I could spend a whole hour talking about it, but I won't do that.
All right. Well, thank you all so much. And thank you all for sticking around and listening to presentations. Hope you all have plenty of questions for March 22nd. So we'll give another round of applause for our presenters, and we will see you all on the 22nd. So thank you.